Thank you, Mickey. Pleasure to be here in the Holy Land, our adopted home. I was going to present in Hebrew, but I'm going to do it in English because I understand there are some people here who don't understand Hebrew, so I'll do my comments in Hebrew. So it's interesting. I think this will be interesting because there are certain guidelines that are beyond the ACC-AHA guidelines that really don't get very much mention. And so we'll really spend a little bit more time on some of these other guidelines. I appreciate the reviews already in the previous presentations looking at the ACC-AHA guidelines. But what's, one of the issues with why the guidelines are so, there's so much variance is, number one, what kinds of evidence they include in terms of guideline development, the thresholds of risk in terms of what determines a patient to be considered high risk, medium risk, and we talked about even the differences between the Europeans and the Americans in terms of the European guidelines being based on mortality versus the American guidelines being based on cardiovascular events. And this is data taken recently from Rotterdam, and what they looked at is they looked at a population of about 7,000 adults, and in that population from that study, they said, okay, let's see what percent of patients would fit the European guidelines, what percent of patients would fit the American guidelines, and where they would fit both guidelines. I think what's interesting here is, first off, these are the patients who don't fit into any particular guideline. You can see here in the blue, these are the patients who would fit into the European guidelines, and the bigger circle represents the patients who would be fitting into the ACC-AHA guidelines, which is consistent with what we've been hearing earlier, that the American guidelines really do contain a larger population of patients who would be considered statin eligible in terms of treatment. So when we talk about guidelines, there's really much more than the ACC-AHA guidelines. We have what we've already discussed from the other speakers, the 2013 ACC-AHA guidelines. We've talked about, actually it's not the ACC-AHA update, it's the ACC guideline update. It's not really itself a guideline, but really represents an update by some of the writers on the original guidelines. We have the National Lipid Association from 2015. We have the very recently presented guidelines from the American Association of Clinical Endocrinologists. We also have the American Diabetes Association has weighed in with their own guidelines. And even the Veterans Administration, Department of Defense in the United States have their guidelines from 2016. And I think an important guideline that you probably haven't heard really anything about, and what has really has recently had a lot of press coverage, is the United States Prevention Task Force, and these guidelines were presented in 2016. So the question in the United States is, it's very confusing. Like, which guidelines do you pass, and which guidelines do you concentrate? A lot of different directions. Do not enter, no left turn, no right turn. This is a corner, Mickey. This is on Brighton and I think Brighton and is it Cannon. So it's very confusing in terms of what we do in the United States. In fact, this was I took from a publication just yesterday. Top News in Family Medicine, dueling statin guidelines put 9 million Americans at crossroads. These are patients who actually do not fit into both guidelines. So these are some of the publications that have been used in terms of guideline development. These are clinical trials that date back to as far back as when I was a fellow, and more recently, these are all studies that you're all well aware of. And this is where the notion of treating to percent reduction versus goal, a numerical goal, came about because these trials did not state a particular numerical goal in terms of their goals for therapy. And I'm not going to spend too much time on the ACC-AHA guidelines from 2013 since they've been reviewed by a number of the speakers. But basically, the people who fit into the guidelines in terms of prevention using statins would be those patients who are over the age of 21, and these are patients for the most part who would be considered candidates for statin therapy, generally secondary risk factor modification. And it also includes basically those patients who are over the age of 40 and under the age of 75. So as mentioned, we really don't have a lot of guidance in terms of the particularly elderly population, which have the highest absolute risk for developing complications of cardiovascular disease, and the younger patient populations. And this gives us the indications in terms of statin therapy, certainly clinical ASCVD. Those are patients who've had overt manifestations. We're talking about, for the most part, high-intensity statins, unless you're over the age of 75. Those patients with LDLs over 190 milligrams per deciliter, many of these patients represent the heterozygote for familial hyperlipidemia. Because there's such high risk, the recommendation, again, is for high-intensity statin therapy. The diabetic, also the recommendation for high-intensity statin therapy, particularly if they have by the pooled equation, they have cardiovascular risk, 10-year cardiovascular risk in excess of 7.5%, otherwise moderate intensity statin therapy if they're considered lower risk by the pooled cohort equation. But what's more interesting is really the recommendations for primary prevention. And that's where you get a lot of discussion in the United States. So for primary prevention, we're really talking about looking at patients who have LDLs between 70 and 190. Those patients, as I've mentioned, over the age of 40 and under the age of 75. And you can see here how the recommendations fared out in terms of utilization of statins. Recommendation, if you're less than 5% risk, or even if you're age 40 to 75 and your LDL is below 190, they really don't recommend statin therapy. If your 10-year risk for a cardiovascular event is 7.5% or higher, the recommendations for moderate or high-intensity statin therapy, and between 5 and 7.5% moderate intensity statin therapy, although you can modify your approach based on calcium scores and other risk factors that are not taken into account in the equation. So this is what the population distribution using the pooled cohort equation, looking at the communities that it was assessed in the United States. And you can see if you're looking at the 7.5 and above threshold, this is what we're talking about in terms of those patients who would be considered for statin therapy for primary prevention. And so I think this gives you a pretty good idea in terms of who would be eligible by percent. What's important about this pooled cohort equation is they do make an emphasis that this particular population does take into account the African American population, but it really does not include other significant populations in the United States, such as Hispanics, Asians, and American Indians. And what's important is that the Hispanics and Asian populations actually tend to have a lower risk than the Caucasians, and the patients who are from American Indian heritage tend to have higher risks. And now you can look at all these different risk scores, and depending on how you want to place your patient, you can actually define the particular risk characterization. But you can see you have the Framingham study, ATP3, and you can look at the different components in terms of the demographics of the patient: age, sex, cholesterol, total, HDL, LDL, and a whole variety of other covariates that are used in these various equations. Now, it's interesting, when the 2013 ACC-AHA lipid guidelines came into account, it really did have an effect in terms of how we treated patients. So, for instance, if you look at when the guidelines took into effect, all of a sudden, there were large numbers of patients who were not being treated with statins, over 30%, who actually became eligible for therapy. There were a large number of patients who were actually receiving non-statin therapy, who it was felt that they no longer needed the therapy. As you know, the ACC-AHA 2013 guidelines really poo-pooed non-statin therapies, had severe emphasis on the use of statins. So the 2013 guidelines really did have an impetus in terms of shifting patients from non-statins to statins, and actually also increasing the access of patients, or the recommendation for patients to be on statin therapy. So then if you're looking at it, and I know many of the guideline writers personally on the ACC-AHA guidelines, and you talk about the fact of why did you not include numerical targets, and they're very defensive about it. So you got to be very careful how you discuss this issue. But this is actually from an official ACC, publication. Why not continue to treat the target? Major difficulties, current randomized clinical trial data do not indicate what target should be. unknown magnitude of additional ASCVD risk reduction with one target compared to another, which I think most of us realize that common sense would dictate that that's not necessarily the case. Unknown rate of additional adverse effects for multi-drug therapy used to achieve a specific goal, therefore they did not recommend non-statin therapy, and therefore unknown net benefit from treat-to-target approach. So that's the excuse that they used. However, as we mentioned, the U-turn, the famous U-turn, so what was the rationale for the 2016 ACC consensus update? And I would say the major push for the update was the fact that trials such as Improve It all of a sudden showed that on top of statin therapy, you were able to achieve reductions of cardiovascular events. In fact, I think the Improve It trial showed reductions of events consistent with what we see with the curve that was shown in terms of reductions of events versus LDL reduction. You get about 15% LDL reduction, and in this particular trial, you basically achieved about a 7% reduction of cardiovascular events, though it did take a long time, but it also was given to a high-risk patient cohort that were reasonably well treated. They had LDLs before randomization less than 70 milligrams per deciliter. And so this was the rationale, really, was to introduce the utilization of non-statin therapies, and they looked at the same populations that were addressed in the original 2013 guidelines. Remember, this is not a guideline, this is an expert consensus update. So this has not really been implemented in terms of the guidelines, and one of the biggest effects in terms of the update was the greater emphasis on non-statin therapies, including the PCSK9 inhibitors, in addition to ezetimibe and the bile acid sequestrants. And these were recommendations to consider addition in your more high-risk population. So, for instance, in this particular graphic, if you were over the age of 21 and you actually had overt atherosclerotic coronary vascular disease, even without comorbidities. Comorbidities could include, as we've talked about, LPA, very high cholesterols, it could include chronic kidney disease, proteinuria. So the recommendation was that if you did not achieve this LDL reduction of at least 50%, or as a secondary goal less than 100 milligrams per deciliter, you would certainly consider the use of a non-statin therapy such as ezetimibe, a bile acid sequestrant, or PCSK9 inhibitor. And certainly with added comorbidities, now you were able to consider utilization of these compounds if you were not able to achieve LDLs of less than 70 milligrams per deciliter. So with comorbidities, they actually lowered the threshold for consideration of these non-statin therapies to less than to patients who had LDLs of at least 70 milligrams per deciliter. And they also include the other very high-risk cohort, those patients who had LDLs of 100 and 190 or more, and this constitutes, in large part, those patients with familial hyperlipidemia, and which is illustrated in this particular in these two particular slides. This would be the patients with LDLs of 190 or greater, who also have comorbidities, and here the recommendation was to actually consider these therapies if LDLs were over 70 milligrams per deciliter. So the emphasis on the 2016 was really to establish the non-statin therapies as second-line therapies. They have not yet been implemented into an actual guideline update yet. So then the U.S. Preventive Task Force, which actually makes recommendations on a whole variety of issues, the utilization of PSA testing, a whole host of issues. And what they lifted the threshold for patients who were to be statin eligible, because in order for patients to be statin eligible, according to the task force, is they not only have to have a 7.5% or greater 10-year risk of an event, but they also have to actually have a risk factor. In the United States, if you use the pooled cohort equation, basically anybody over the age of 70 will almost fit into the utilization by virtue of this equation, because it really is so age dominant in terms of defining the 10-year risk. So what they basically did is the U.S. Prevention Task Force, they raised the threshold in terms of defining the patient at risk, and they also lowered the recommendation for utilization of statins more to the medium intensity statin therapy versus the high intensity statin therapy, which is utilized more in the ACC-AHA guideline. So the world of patients that are recommended by this task force is actually smaller than the ACC/AHA guidelines, and the intensity of statin therapy is also lower. Again, they didn't touch the patients who were over 75 years of age, not because they didn't feel that it had there was positive implications for therapy, but because there was really a dearth of or lack of clinical trial data looking at this particular age group. So this is the recommendations by the U.S. Preventive Task Force for 2016. This was published in JAMA in late 2016. And what they felt was the population of patients between 40 and 75 with no history of CVD, who also had one cardiovascular disease risk factor and an event risk of 10% or greater by the pooled cohort equation, they recommended the use of low to moderate dose statins. So you're talking about a higher risk cohort and a lower intensity of statin therapy. They felt if there was 40 to 75 years of age, no history of CVD, but you had at least one cardiovascular risk factor and a calculated risk score of 10-year risk score 7.5 to 10%, they actually did not feel compelled to recommend therapy, but to have discussions with family members and the village priest in order to determine whether there should be utilization of statin therapy at all. And then you had the adults who were 76 or over, where there was no recommendation for therapy. So this is really, if you look at this particular slide, this really shows you the difference between the 2013 and the Preventive Service 2016 guideline. And I think second to the ACC/AHA, the U.S. Preventive Services Task Force guidelines are really second in terms of notoriety and getting press. And what you can see here is that these are the populations that are covered by the 2013 guidelines, and these are the populations that are covered by the 2016 guidelines. Again, the preventive services covering fewer patients and recommending lower intensity statin therapy. So if you look at the right under the table, what you see is based on the NHANES data from 2009 to 2016, the prevention service guideline would lead to treating 16% of adults in the United States between the age of 40 and 75, compared to the 2013 ACC/AHA guidelines, which would recommend treatment of about 24%. So you can see there's almost a 1/3 reduction in terms of the patients who would be treated by statin therapy. It looks a little bit more like the kinds of outreach you see with the European guidelines, in fact, although the European guidelines certainly recommend higher intensity statin therapy. The point of this slide, this is looking at patients who would have been eligible for statin therapy. And what we see here, what's interesting, this is where there's concordance between the two guidelines. It's, certainly the vast majority of patients. But this is the patients who would be considered statin eligible by the U.S. Prevention Service, but not the ACC. It really is 0.4%. So very few patients would actually be considered eligible by the Prevention Service and not by the ACC/AHA guidelines, whereas about 9% of the population would have been considered statin eligible by the ACC/AHA criteria, but not by the U.S. Preventive Services Task Force. But then we also have the 2015 National Lipid Association guidelines. Is the audience pretty familiar with these guidelines, or is that something? So now the nice thing about the National Lipid Association, it gave people like me who actually like to treat the target, the ammunition to do so. So one of the big effects of the NLA guidelines is to provide that numerical target to treat. And there really isn't much new in terms of these targets. The guidelines are now over 2 years old. And again, what they recommend for, as we feel comfortable, those patients who have ASCVD and diabetes type 1 or 2, the recommendation for treating to an LDL less than 70 or a non-HDL level as well. So now we'll get to the diabetic patient, because I think we now have some very new guidelines with the diabetic patient, and I think that the newer guidelines, you're starting to see LDL reductions that are lower than what we've seen in the United States with that threshold of 70 milligrams per deciliter. And what's interesting is that in the diabetic cohorts, what they found basically was similar to the non-diabetic patient. There was about a 21% reduction in major cardiovascular events per millimole per liter. So with per 40 milligram per deciliter reduction in LDL cholesterol. And this is similar to the non-diabetic patient. And the other important aspect, since really the type 1 diabetics are not well represented in the statin clinical trials, from whatever little bit of data that we were able to glean from clinical trials, and in particular their cholesterol treatment trialists collaborators meta-analysis, is that the type 1 diabetic does seem to have similar reduction in terms of cardiovascular events as the type 2 diabetic. And what we see from the improvement trial, where was most of the reduction of events in these patients? It was really in the diabetic population. And so many of these trials, if you pull out the diabetic population, there really is not a significant reduction in cardiovascular events. So the recommendation of the American Diabetes Association are the following. So they actually will achieve, looking at the utilization of high, moderate intensity statins, so they're kind of stuck in that particular situation. The one exception would be in those patients who are statin intolerant, who have had an acute coronary syndrome. The recommendation would be to consider lowering LDL levels of less than 50 milligrams per deciliter. So now to make things even more complicated, you have the 2017 American Association of Clinical Endocrinologists guidelines. They are more numerically based, and I think the one point that's worth mentioning is, again, they're also achieving a lower risk threshold for LDL reduction, and this would be patients who have progressive atherosclerotic events on statin therapy, patients who have clinical cardiovascular disease with diabetes, class 3 or 4 chronic kidney disease, and premature atherosclerosis. So what we're seeing also in the United States, as the new guidelines become updated, we're starting to see lower thresholds in terms of goals for LDL treatment. So how will the new data affect the guideline updates? We've alluded to what was just presented, the Fourier trial, which was a trial, unfortunately, that was cut short because the sponsor of the trial added patients in order to more quickly get the number of events to end the trial. So what you can see, unfortunately, the trial really went to about 2-year mean treatment. The spread in terms of events really occurred within the last 6 to 9 months. So although it did show a modest reduction of cardiovascular events, perhaps underestimating it because of the shorter duration of the trial, we do have the Glagoff trial, which was an angiographic regression trial, basically showing that once you get to LDLs of about 50 milligrams per deciliter, 55 milligrams per deciliter, that's really start seeing atherosclerotic regression. Although we not yet have been able to connect the dots in terms of angiographic regression and reductions of cholesterol and reductions of cardiovascular events. And this is, again, I've participated in all these trials as a PI, but I think the SPIRE trial actually gets the least amount of attention, I think has the biggest impact. This is a trial that, again, looked at a higher risk patient population. The duration of the trial was longer than what we saw with Fourier, and what was interesting in the SPIRE trial was a more significant reduction of cardiovascular events. You basically achieved about a 21% reduction. So then, therefore, it's a new world. Coronary regression seems to occur at LDLs lower than current guideline recommendations. As anatomic regression associated with better outcomes. SPIRE 2 and Fourier have shown significant reductions on top of maximally tolerated statin therapy. Safety does not seem to be an issue when achieving very low LDL levels. I do suspect that Odyssey will show even greater cardiovascular event reduction because it's longer duration and the higher risk patient cohort. Achieving LDL levels below 50 milligrams per deciliter in very high-risk populations is probably going to be something we're going to see recommended in the upcoming guidelines. Probably see more widespread use of PCSK9 inhibitors, particularly if Odyssey outcome shows a greater cardiovascular outcome reduction than we saw with Fourier and closer to what we saw with SPIRE. And I think we're also, as we all, I think, agree in this audience, greater emphasis on imaging modalities such as coronary calcium score and carotid ultrasound to identify the higher risk patients. So thank you very much, and I appreciate your attention.